You ready? Very good. OK. So I would like to introduce our next speaker for this afternoon, Milos Popovic from the University of Toronto. Milos started his studies in Serbia, the University of Belgrade, where he completed his diploma in 1990, and then moved to Canada for his PhD. Spent some time in our lab. I think Manfred will say a bit more about that time in his life, then moved back to Canada. And he works on topics, biomedical topics, control of biomedical systems, prosthesis, rehabilitation. And in addition to academic achievements and academic recognition, he's also known for his entrepreneurial and technology transfer work, founding companies and competitions, awards in this domain, and so on. So, Milos, it's a pleasure to have you.
So when I came to ETH in 1994, there was Professor Gladfeld. I'm not sure he's here now. But he had started and was involved in a project in biomedical engineering, specifically together with the Paraplegic Center, University here, Balgrist. And but it was clear that we were a little bit too removed from the details of this activity, and so we were looking for somebody, senior researcher, to take over and help with that. And so I contacted one of the leaders in this area, Professor Dejan Popovic, who was posted in Miami and in Belgrade, had appointment, and actually also in Denmark. And he recommended Milos. And so I said, that really sounds bad, you know. There's Dejan Popovic recommending Milos Popovic, so this it seems like nepotism. But then it was clarified that Popovic is something like Smith, I think. So Milos did an excellent job on building up this group that then continued. People like Terry Keller, who is here. And then Robert Rina was hired for this group and actually formed one of the foundations of the Department of Health Science and Technology, which was more recently founded at the ETH. So thanks very much, Milos, for coming. And
thank you very much. It's really a pleasure. This is my title. I'll talk about neuroprosthetic systems and how you can use them to improve outcomes in stroke and spinal cord injury patients. Just one more thing. I actually also have an appointment at Toronto Rehabilitation Institute, and all my operations physically are there. So I have three disclaimers. First of all, I'm a shareholder in this company. So whenever you see the name of the company or the product MyndMove, don't trust me at all, right? Second disclaimer is I will show not a single equation today. I apologize profusely. And the third one is I actually brought a jacket, and I was trying to look professional. And as I was putting it on, I couldn't put a jacket on. I thought, oh, man, I got fat in Belgrade. I was just 3 days. This is horrible. Then I realized it's actually my son's jacket. So that's why I look like this. So it was kind of an embarrassing moment. So how I met Manfred. Manfred gave you a little bit of color on that. I'll give a little bit more, and I hope you will not be bored with that. I used to, when I graduated, got my PhD, it was in robotics. I started working for Honeywell Aerospace. At the time, they were called Allied Signal Aerospace, and nobody knew who these people are because they were running all these submarines and nuclear weapons and all other things. And only later, when they got out of the closet, they bought Honeywell, and they now are called Honeywell. And I was working on this particular airplane, and I was having a blast. I was learning a lot, and everything was going quite well, in my opinion. And then one day I got a phone call from this gentleman, Dan Popovic. He says, there's a wonderful job opportunity at ETH, and they're doing neuroprosthetic systems, and you should really apply for that job. And I said, I mean, I don't know what a neuron is. Why would I apply for a neuroprosthetic position in the first place? And Dan, being a proper serve, he's just shut up and send your CV. So, me being respectful of him, I sent my CV, and that's how I met Manfred. And actually, I was in Belgrade visiting my parents. I flew through Zurich. I called Manfred. I said, I'm in Belgrade. And he says, why don't we meet and have a couple of minutes chat? And actually, my interview took place at this institution, airport. It was different at that time a little bit, but that's where we met. We had a couple of beers, actually, and we're talking about meaning of life. And I fell in love with Manfred in the right sense of that word. And I go through all kind of different set of interviews because he wanted to check if I'm really the right person for that. And eventually, I got a job offer. And one thing which I didn't really understand at that time, being an ignorant idiot, was that besides Manfred being a phenomenal individual and what he has accomplished, I got another hat trick. I was given an opportunity to work also with Volker Dietz. And for those of you who are not working in that field, and many of you are not, he was at that time top 10, if not top 2, 3 people in spinal cord injury research, and he was a neurologist. So that Manfred was my direct mentor. Volker was giving me space to work with, and I was given an opportunity to work with this individual, Thierry Keller, who actually taught me everything at the beginning, because I came as a total ignoramus. I was reading at Kendall's book, physiology, and chapter 84, neuron and mitochondria and this type of things before I came. And still, I can't believe that this happened. And every now and then I look at this image where you see him and our patient, so Thierry and a patient, and he hasn't changed at all. And I just look a little bit less goofy than that time. But it was real. It happened in the hospital. And everything that you see today came from that event. And I'm extremely grateful for Manfred taking a risk on me and giving me an opportunity to work in the field. So why are we doing this in the first place? So I'll show you 2 videos. Both of them are kind of emotional. And so hold you to your seat. So this is a stroke.
April 2nd at 6:42. And the sensation is happening again. Just smile, they said. Smile.
So she does not know what's going on, but she's having a stroke on the right side. And you can see her face is drooping. And she's
on the left side. The doctor said to breathe in, breathe out, manage distress. And I'm trying. I don't know why this is happening to me. It happened this morning again. And when I left the hospital Monday night at like 12:30 in the morning. So now I'm taking a picture for an example of what happens. It's 6:43. My hand is hard to lift up and to touch something, touch my nose. Okay.
So by this time, she's having double vision. That ability to touch her nose gets diminished. In about 15, 20 minutes, the face is completely sagging, and she can't use her arm. So this is about 3 weeks after stroke. Typical stroke outcome. He has no functioning shoulder, elbow, wrist, and fingers. And whatever Jennifer is showing him, that's what she would like him to do. And you will see that patient is not able to do that. What he has on his hand is just to protect him from an injury and not allow fingers to crawl into the fist. So he can't even extend his wrist or his fingers and such. So these are some of the statistics. Just in Europe, in the United States, Canada is really insignificant, it's only 30 million people. In these 2 jurisdictions, there's almost 2 million new strokes every year. 50% die within a couple of days, and 10% recover completely. The remaining group has moderate to profoundly affected upper limb. So you see the numbers are ridiculously high. I'll show you another video of the spinal cord injury. This is not for those who are who have a weak heart, so boost your pacemakers. I'll make it really short. It actually happened in Germany recently. Sorry.
Was für ein Gefühl muss das für diesen Vater sein, wenn ihm sein eigener Sohn vors Auto läuft?
The reason why he's not moving after that is not because he's unconscious. He just lost control of everything below the neck down. And this is a typical outcome after that. So when you stabilize the spine, cervical spine, this is what the patients are who have a cervical injury typically able to do. He's about C6, C5 spinal cord injury patient. And you can see he cannot use his fingers, he cannot use his wrist. And it's quite devastating. The challenge is when you run them through conventional occupational therapy, either stroke patients or spinal cord injury patients, they improve gently, as I'll show you some data later, but they usually depend on others, on activities of daily living. The numbers, fortunately, for spinal cord injury are much smaller, only 34,000 patients. And these are, for example, those who have tetraplegia, which is about 20,000 individuals in those jurisdictions. Now, what is interesting is this. The burden of care for those individuals is ridiculous. For stroke in the US alone is $34 billion, and most of that is trying to care for their daily needs. And one of the biggest chunks of that is them not being able to do things on their own. So if you want to try how that looks like, an elegant way to do is put the arm in a pocket and try to take a credit card out of your wallet. It's mission impossible. Can't do that. With spinal cord injury, even though the population is much smaller, the level of injury and what happens to them, because it's bimanual, both hands are lost, the numbers are comparable. Actually, individually, spinal cord injury patients, cervical level, cost the system about $5 million for their lifetime costs and expenses. And by the way, the stroke is the leading cause of disability in any jurisdiction that you may know. So when I joined Manfred and IFA, there was this device which is called neuroprosthesis, and this particular device that I'll show you is neuroprosthesis for grasping. And the way how it works is very elegant. You have actually natural difference in the voltage on the axons. So they're about minus 90, minus 80 millivolts. And if you are able to provide the electrical field to change this positive charge on the outside of the nerve, you can open the sodium-potassium gated channels, general action potential, and generate a muscle contraction. You don't have to be naked to get a muscle contraction, but it's an option, right? So how does this actually work? And this is one of the Thierry's images, that's why I brought it today, is essentially if you find the right muscles, and if you contract them with the proper intention, you can generate different hand functions, or different functions, hand opening, hand closing. And this is one of the videos that Thierry and I made almost 15, 16 years ago. Is where you have a patient which has an instrument in the left arm, and he's a spinal cord injury patient, and you will see he will try to lift an object, and he can't do that, and then he will activate the neuroprosthesis with a push button to grasp the object and to manipulate. So when we designed that, the vision was that these patients are going to use this as an assistive device, which means they're not going to improve their upper limb at all, and if the improvement happens, it's going to be minimal, and it will only happen early in the rehab. But they will depend on these devices. And everybody who was in that field at that time was pushing that agenda. So they were trying to do this, create a technology that patients will use as orthosis, which means they will have it either implanted in the body, this is a freehand system, which is not available any longer, or they can be on a surface of the body, and patients will use it every day in order to grasp and release objects. So when Thierry and I started doing that, we actually discovered that some of the patients, as you give them this therapy, start having some improvement on their own. And as I moved to Toronto, I actually tried to pursue that particular concept. How far can you use this technology? Not as an orthosis the patient has to take home, but as a technology that patient can use to retrain the hand function. Fast forward 15 years later, this is what's actually what we know so far. So how does this technology work? You actually ask the patient to do tasks that he can't do himself. You actually instrument the arm, and you ask the patient to, for example, open a hand. And patient will struggle to open a hand. And of course, he won't be able to do anything, or very little. And then you fire all the muscles that he would normally use to open a hand. And then hand opens naturally, or looks like it's opening naturally. And then you ask them again to close the hand, same process. You wait for them to struggle with that. And then you fire the muscles again, and you close the hand. And by doing this and other reaching and grasping movements over time, you try to retrain the brain and the central nervous system how to do this task voluntarily. So schematically, this looks like that. So somebody had a stroke, part of the white matter or gray matter is gone. You cannot either generate the command or you cannot send the command to the structures, or both. And then what you do is you apply electrical stimulation electrodes on the patient. Then you ask the patient to start thinking about particular movement. You tell them specifically what you want them to do, for example, touching the nose. And as the patient is struggling to do the movement and fails, of course, you fire the muscles, you get the muscles to perform the movement, and then you get a feedback coming from the muscles back to the central nervous system. And with repetition, you create new structures in the brain, engage new structures in the brain and new pathways to send a command to the muscle and to retrain, to enable patient to do the task himself. So there are three critical components in this. So I'll start with the first one, the patient. The patient actually needs to participate in a process. This is as much as technology as a learning process. So the patient has to know what task you want to do with them, has to actively participate in the process, has to understand. So if the patient is cognitively incompetent, there's no point in trying to do this. Second thing is you need the therapist. The therapist actually has to figure out what are the tasks she or he would work with the patients initially and where to start. Because patients are, imagine yourself, we're all complicated people. You want to see early gains, and if you don't get early gains, you get disenchanted, and you don't want to participate in anything that takes 40, 60 hours. So the therapist actually picks a therapy that could engage the patient early and get some early gains so that patient will stick with the therapy. And then you need the device which will produce all those fine motor control and gross motor control that you need to teach the patient. And I'll tell you more about it in a minute. So here's the technology that we have developed over the years. So this is a system for reaching and grasping. So this is some of the placement of the electrodes. So this is frontal deltoid muscle, just to move the shoulder even forward, pectoral muscle, biceps. This is extensors. This is finger flexors. And we also stimulate intrinsic muscles. And this is what you get. Reaching forward and hand opening to pick an object, reach the object, retrieve it back. Or pinch grasp, or lumbrical grasp by holding the book, or the Kermit the Frog Muppet thing. You can do that. Key grasp. And then you can do it by manual. So you can use one hand to pick an object, bring it to another hand, release it with the other hand, or actually pick a tray and do something with that. This is how the device looks like. It has actually has now 32 different protocols, which were originally designed 17 for stroke and 13 for spinal cord injury individuals, but now therapists like to mix them and do it in whatever way they want. And there's all kind of reaching sideways, reaching to the nose, and pinch grasp. We even have an option for smokers. You can do this. Not that we encourage smoking, but there's an option. This is a touch screen, so the therapist can go through, pick up whichever of the therapists she would like to run. She has a record, what happened, and then when she goes to this begin treatment, gets where the electrode should be placed and suggested intensities and whatnot. So it walks you through the process, and it's kind of very helpful that way. So here's how that looks like on a stroke patient. So that lady was 2 years post-stroke. So she had no movement in her hand or arms, and everything that you see is actually done by the system. Normally, it's done only by one person. You don't have two individuals, and that's how that works. That's an 8-channel system, so you have up to 8 muscles that you can contract and activate to do the task. Now, here's a very important thing is when you design a system like that and you start getting some changes and improvements, this is all very nice, but unless you do randomized control trial in which you have one patient in one group and another in another group, and you properly randomize them and assign them, your technology doesn't have any chance to be accepted by clinicians or even get commercialized. So in order to do that, we had to run a couple of randomized control trials, and I'll show you the results of one of them. This is a clinical trials in subacute stroke patients. Subacute means less than 6 months after stroke, and here are the methods of it. So that was, as I told you, randomized control trial, which means as the patients come, we pick them up and assign them to one or another group. We had the intervention group and a control group. Control group got the 1 hour of conventional therapy. Conventional therapy means the best therapy that we give for upper limb. That's what they got for 1 hour. And the treatment group got 1 hour of the therapy, which I showed you a few minutes ago. They got this therapy 40 times. So they have 40 sessions. And they were all subacute, shadow muscle stages motor recovery, 2 or less than 2, or Fugelmeyer, 15 or less than 15. In simple translation, they couldn't do anything with that arm. They could not touch their lips, they cannot reach things, they cannot grasp things, they can't do anything with that. Okay? So here are the results. We had 21 individuals in the study. They were all between 70 and 57 days post-stroke. There was only one individual which was 17. Everybody was more than 21 days post-stroke. And 11 patients were in control, and 10 were in intervention group. So this is an important one, because as an engineer, you get very excited if you can move the finger and what is the range of motion, all these type of things. And when you present this to the medical doctor, he goes like, totally disinterested. So what community wants to see is what the patient is able to do in real life. So can they feed themselves? Can they bath themselves? Can they dress upper body, lower body, groom themselves, and toilet? If they can do that, they're interested in your technology. If they cannot do that, then they don't care, right? And this particular scale is called function independence measure, and it goes from 6 to 42 points. Obviously, an engineer didn't design this test. Otherwise, it'll go from 0 to something. And anyways, the minimal clinical important difference is 6 to 8 points, which means if you make the change of 6 points, the insurance company is interested to pay for that. So this is where our patients start. So that's minimum. And a few of them were wherever. This is a control group. This is a treatment group. These are individual patients, 1 to 11 and 1 to 10. That's before. This is after. The red shows you the difference. So the improvement, immediate improvement here, it's 8. Here's 22 points. I don't want to show you statistical analysis. This is statistically significant, but it's not relevant. This is the ocular statistics. So what does it mean? So if you're in a controls group, this is where the patients were. So 7 patients here, 4 patients there, and the treatment group, that's the distribution. This is after 40 hours of therapy. This is after 40 hours of therapy. You don't need the p-value to know in which group you want to be. There's another test which is actually telling you what the hand is actually doing and shoulder. So this is called Fugelmeyer assessment. It's an upper extremity test. It's a shoulder, elbow, forearm, wrist, and hand. Starts from 0 to 66 points. And again, clinically important difference is 6 points. This is where our patients start. They're less than 15. So the reason why we stress this 15, less than 15, because people don't work with patients who are less than 30 points on Fugelmeyer scale. Typically, they don't do it because these people don't improve. So if you are a patient, you had a stroke, and 3 weeks after your stroke, you come to your MD and they assess you with Fugelmeyer score, or your therapist, and the therapist figures out that your score is less than 30, she'll say, okay, now we'll do balance. What about my hand? Maybe later. Let's work on balance and locomotion, on sitting and swallowing. They totally neglect your upper limb, usually. This is the difference after. So this is after 40 hours of conventional occupational therapy. This is after 40 hours of FES therapy. We have one patient who had spontaneous recovery, which is great, and another one which also made clinically important difference, and none of the other patients. So the median gain here is 0, here's 24.5 points. This is why they don't work with you. Not because they don't want to work with you, because they're lazy, because they will spend 40 hours trying to work on your upper limb, and probability of improvement is very, very slim. So this is how this looks like. That's the same patient 40 hours later, or 40 sessions later. No. Stays. Gets better. Gets better. The question was, does it change with time? No, it stays, and it gets better with time. And I'll explain in a minute why. So when we publish that, you know, there's always this little question, is this some Serbian stuff? Is he doing some illegitimate science there, right? Because, you know, they don't really trust the boys with funny looks. And so what happened was one of the preeminent neurologists in Toronto, her name is Sandra Black, comes in and says, can I try your technology? But she's very kind and very smart, sophisticated. I said, sure, you know, would you like me to send you my therapist? No. Why don't you give me the device? So we gave her a device. We trained her therapist to deliver the system. And we had one patient with her. I'll show you the video of that patient, and then I'll tell you later what happened, okay?
This big 300-pound guy had the ball and he came running like straight at me. It went horribly wrong. I immediately realized, well, I have a broken face because my jaw was over here.
It was so serious, they didn't know whether Andrew would survive the stroke. Well, we were fearful that we might never hear our son's voice again, or that he might not ever be able to walk again or use his hand or arm.
If somebody has a high-level stroke injury, probability of improvement is less than 10%.
So basically with functional electrical stimulation, we are retraining function. One component of the signal goes to the muscle, but at the same time, we are also sending a signal to the brain of the movement that's being executed.
They were saying that it would train the muscle, and my brain would obviously connect that pathway.
Within months, we could see improvement.
Very encouraging, like we saw hope.
It did wonders for me. It pretty much gave me back my arm.
If it wasn't for the functional electrical stimulation, he wouldn't be what he is today.
It definitely has made a huge difference for him.
During rehab and FES, it's been great for me. It's basically got me from dependent to independent.
What is interesting about this video, we actually worked with him. He improved his hand function. You saw in the videos he was able to lift some objects. And then 7 years later, Toronto Rehab was trying to push a little bit of, you know, PR thing. And says, oh, do you have any of your patients that we can film? So we kind of, you know, other people have died in the meantime because they're, you know, 70, 80 who had strokes. So we knew this guy's probably alive. So I said, why don't you go and film him? So they go and film him. And so how's the video? Great. I haven't seen it. I haven't seen patient for 10 years. They brought the video, and the guy's doing chin-ups. That was not on the menu which we were offering for our patients. I mean, we hope that they're going to be able to do something with the hand, but not that they're going to be able to do that. Now, the next one, which is important, is this is after we launched the product. And this is chronic patients. They're at least 6 months after stroke. Again, their Fugl-Meyer was less than 19. But the company decided not to give them the full dose of the therapy. We recommend at least 40 hours or more. They decided to do 20 hours. They want to see what happens. And by the way, when they built the product and they trained the therapist, I didn't participate in that process. I have no idea who the therapist, or I don't know who was training them. So that all happened without me. And many of these therapists actually dislike electrical stimulation before they start doing this. So there was a clear bias to the other side, right? And again, minimal clinical difference, about 6 points. So these are the results. Patient 1 to patient 22, 24. This is where they started. This is what they got after only 20 hours of therapy. So 2 patients had no improvement whatsoever, and this is what they got. Knowing that these are not an experts in the field, these are people for the first time use our therapy, and we're just launching the product, and we're still trying to figure out what to do right and what we're doing wrong. I was very pleased with that. So out of 24 patients, 14 received minimally clinically important difference, and that's only with only half of the dose of the therapy. So this is an interesting case. The reason why he's interesting, he was 19 years after stroke, and he's financially very competent. When I say very competent, he can buy any of the departments at ETH in a single sitting, right? So he had a therapy every day. The most expensive therapist that we can find in Toronto, she was working with him for 15-something years. And he had no movement in his arm. So when he came and says, will I benefit from this? I said, no, probably not. I mean, it's been too long, and you've been treated really well, so I don't think so. So this is 20 hours later. That was filmed at a family dinner party. And this is him after 60 hours of therapy. And that's his quote. I'll show you another one. So this is the patient, which just started at some point in time, just a couple of months ago. And this is 13 sessions later. The conclusion is very simple. It works very well. It doesn't work with every single patient, but it works with a huge number of them, and it's transformational. Now, there's another thing is when you do design a medication, you usually design it for one patient population. It's very seldom that one method works for 2 different patient groups. So this is a second patient group. I'll go quick through that. These are spinal cord injury patients. Similar methods, 2 groups, the control group and intervention group. But this time our ethics review board got a little bit more intelligent, right? And tougher. So they said, no, you have to give both groups 1 hour of occupational therapy because they're entitled to that. Because we know they're improving as a result of that. So then we give them 1 hour occupational therapy to both groups, then 2 hours break, and then another hour occupational therapy for the control group and FES therapy for the treatment group. And this is what we got. So we had 21 patients. They were all subacute, 12 in controls, 10 in treatment group. You saw that test, so I'm not going to go through that. This is where they started on a FIM score. This is where they ended up, 9.25. And here's another one. This is the spinal cord independence measure, looking at feeding, bathing, upper body, lower body, dressing, upper body, lower body, and grooming. Goes from 0 to 22, and 6 points is change in neurological level, which means if you have improvement of 6 points, it means that if you were C5 spinal cord injury patient, after that you present as a C6. So this is where they started. Some of them were at 0. This is where they ended up. Median gain 3, here 12 points, which is like 2 neurological levels. So if patient was C6, he got a hand function back completely, on average. So here's the patient video number 1. This is before. And this is a tricky task. It's part of the Toronto Rehab hand function test in which you have to really open a hand, grasp an object, squeeze it, and lift it. You cannot play tricks with it. You cannot use a passive grasp or something funny like that. So that's before. And this is after. This is the second patient. That's before. And this is after. As you can see, there's no electrical stimulation. There's nothing. That's just them. Them, their central nervous system, their muscles. And one more. There's many more videos, but we'll stop at that one. So this is a difficult task because it's a 600 grams object. You have to lift it in the middle, and then we push it to the side to see how you're handling eccentric load on your wrist. Simulates a case when you're holding a frying pan. So you can see at the beginning he was not able to do it. And this is after. And this video is old, but we love it because of this one. So his phone rings, or whatever that was at that time. And he's opening his bag with his both hands. He takes the thing with the touch screen, turns off the phone, puts it back in the pouch, zips it back, and continues the test. Who cares about a test? That's what really matters, right? Now, conclusions are obvious, but there's one thing which now happens, because when you do randomized controlled trials, you really focus on a particular group of patients, you select them very carefully, and you just work with them. And you don't deviate from that. Now the product is out there, and the therapists are using it. They start doing some totally, for us, unimaginable things. They'll take people who, as you see, these people have some function in the shoulder. They are now taking people who have no function in their shoulders or elbows, work with them, and go from nothing to picking up peas and eating it out of the dish. And that's very exciting. Okay? So these are all the people that have participated in this process. And actually, it's many more therapists that added value to that, but these are the key players. Eric Baumann, Kathy Craven, Rob Bonafilippos, Naz Kapadia, Nori Kawashima, Colin McGilvery, Cindy Morishet, Mary Nagai, and Dr. Vera Jovanic. These are all the people who were ill-informed and funded us. And while we were having fun, this is how many people had stroke. So that's kind of a tough message. Are you interested to know what else we are cooking, or should I shut up? 5 minutes. Okay. So this is an interesting thing. That image didn't come through. Anyway, I'll tell you what's happening. We have this, when you do this therapy, you always are asking a patient to do particular movement, and you're watching, the therapist is watching them in their eyes and trying to see when they start struggling or the straining to do the task. Now, the problem is you don't know if they're straining because they have the gesture problems or they're trying to actually move the hand. So you don't know if the intent is the right thing. So we did some other studies, and you have to trust me on that one, to demonstrate that if you can trigger the electrical stimulation with brain-machine interface and trigger in proper time, that the learning is much faster and much more elegant. So one of my collaborators, his name is Cesar Marquez, has recently developed and filed a patent on a way to detect different grasping styles directly from the EEG recordings. And now you can see the first patient. And what is interesting about this patient, which Cesar did not know, was that, you know, these two people who didn't improve from that commercial attempt, we took one of them, and we brought him to, for him to work with him. So this is what you're going to see, a patient who's, so that's where the EEG system, and this is detecting his intent, and this is driving the electrical stimulation. And each time this turns green, they detected properly the intent. He received 40 hours of therapy, and after 40 hours of therapy, he had improvement of about 6 points on Fugumari scale. And we're very proud of that. So we just got the money to do another 10, 15 patients and to actually figure out all the technical elements that we need to do. Remember, we are stimulating them electrically. We're inducing a lot of noise into the system. Despite that noise, we're able to pick the signal and control it well. This is another totally funky thing. These are stem cells. These are neuroprecursor stem cells. And one of the problems in stem cells, for those of you who are interested in that and been following that, is that, yes, they're omnipotent. They can change and become mastocytes, oligodendrocytes, and they can replace the brain structure. But the problem is, each time you take them out of the ventricles of the brain, you germinate them in the container, and you want to put them back, your body reacts with autoimmune reaction. It reacts negatively to its own cells. So that's one of the limiting steps. So we know where the cells are produced. We can actually generate them to produce more, but we cannot take them to where we need them. So this is an electrical stimulation that we have designed and recently filed a patent on that, in which you can see the stem cells moving in the field and very nicely, and you can actually control them like a Pac-Man. So if you create enough complex field, you can drive them up and down, left and right, wherever you want. We tested that in a dish, so this is a dish test, and we tested them on a spinal cord slice, and right now we're doing the tests in mice. So if we pass those tests in mice, that's going to be very exciting. As you can see, this is the field, and when we change the field, they'll go backwards. So there's a change of field, and you can see they all go backwards. This is how the cell looks like when it's magnified. So it's not rolling, it's not a passive thing, but it's actually, cell is actively engaged and trying to get from one side of the dish to the other side of the dish. So we're very excited about this, and if that works well, and we demonstrate it in the next 4 months, then we'll take it to the next level, hopefully. And this one is a really funky one, and I will stop after that. So I was reading some of those CIA books, it's actually how they are figuring out when somebody's lying and they're not lying, and micro movements of the face and stuff like that. The work has been done in 70s and late 60s, early 70s. And there's about 300 pages book, tells you how different micro movements of the face will tell you if you're lying, if you're depressed, if you're happy, if you're stressed, or whatnot. But at that time, when they were doing this, they didn't have cameras like we have readily in phone, and you can film everything that you want to film. But they actually discovered, in order to be able to transmit the knowledge, they had to train people how to make those different expressions, right? So when they were teaching them how to make the expression of being sad, they get depressed. That's a single line in a 300 pages book. So I said, then flip back, and there are different expressions of happy. So there's a happy, which is a CNN happy, which means totally faking, not genuine at all, but it's a social happy, right? And there's another one when you're genuinely happy. When you're genuinely happy, you're contracting this side of the orbicularis oculi muscle and zygomatic major. The catch is you can't control it voluntarily. That's why you can figure out if somebody is really happy to see you or they're faking, because you recognize those little things. You cannot control it voluntarily. So we designed an experiment in which we got able-bodied subjects, and we used the old stimulator. And those of you who know the electrical stimulator, it's not the most joyful experience. That kind of hurts, right? Disclaimer, the new stimulator doesn't hurt at all. That's a new piece of technology that we developed. I forgot to tell you. But these old stimulators, they hurt. So we got the able-bodied subjects. We put this on them, did randomized control trial, and we did a test in which they have to do something cognitively. And we told them what we're trying to do is try to figure out if the pain on the face is influencing their cognitive capabilities. So as they were zapping, then they're doing this, and painful. And then we assessed their cognitive capabilities, but on the side, we did a PANAS test to set their emotional status. And we were able to upregulate their emotional status. So we now have the first patient, which had a depression, went through the process, and we're having a couple of more coming this week. And so if that works, we may get some man in black from Pfizer with machine guns, and we'll be in deep trouble. But we hope to change the way how this is done. And that's it. And if you want to find what else we do, that's the way to do it. Thank you.
Thank you. Thank you very much, Milos. Any questions?
So the question was, can you recover other like sensations? So our focus was really primarily to recover motor function because what it does for the patient. Some patients during that process recover sensory function as well, but not all of them. So no, not specifically. But specifically, we target recovery motor function, and we're able to address that particular thing.
May I ask as well? I noticed in one of the videos there was improvement clearly on the stroke side, but there was involuntary movement on the appeared to be involuntary movement on the non-stroke side. Is this part of the is it a common artifact or?
So the strokes? You mean the gentleman? He was doing both. Oh, that's a very good question. So what is this actually showing you is how the therapy works, because the brain is a distributed system. Like a PC, all the functions don't sit in one hand, in one side. So if you want to control the right hand, 85% of the control comes from the contralateral side, and 15% comes from the contralateral side. So in the early stages of the therapy, you can see that ipsilateral side is driving both arms. And the reason why he's doing symmetric, he's using the same side of the cortex to drive the recovery process. And later, as the therapy proceeds, they start decoupling these two things. So it is not with all patients, but with many patients, you will see that they're, even on the young lady in yellow, you will see that she was trying to open a hand. You probably didn't pay attention, and I totally didn't direct you to that. She was doing it with her less affected arm, because they do this kind of mirror task, because it helps them relearn the function. But the recovery is not really dependent. So if the person has lost, good part of the motor structure, even if the stroke is in the brainstem, we have shown the recovery, even in those patients. Ian.
That was very nice because you get rid of all the cables and it can really help in everyday life. Is this a direction that is still followed by some groups or any company? Because I think that would be a big promise.
So the
implanted system.
Yeah, so we cause them a little problem, right? Because if this works and gets a lot of improvement, their market is shrinking drastically. So they have Cleveland has a really difficult time selling the concept because of that. However, for those patients who do not improve, and there are many of them who've been there and done that, they may want to have an implanted system. The problem is that the business model for that is really not there. There's not enough patients. So Hunter Peckham is trying to revive the company right now, and Thierry would know maybe better than I do. And he's trying to create a non-for-profit organization that will build those stimulators and implant them. And I wish him well. I hope that he does that. But it's financially very challenging, right? Because even when they were successful, out of the 30 patients who will be candidates for that, only one would say that he wants to have the implant. And that was a challenge with patients. How do you convince the patient to get it? Because they were implanting them 2 years after the spinal cord injury. And by 2 years, the patients learn all the tricks how to deal with their life without the system. So not every patient was enthusiastic about it. Maybe rightfully, maybe wrongly, but these are some of the stats that we have.
Actually, I was instructed to tell you there are microphones that work here as well. You just need to press this button. Yeah. And
I was just curious, how do you design the pulses for stimulation? I mean, is there a certain chosen set of signals, or do you guide those choices based on feedback?
Now I mean, the pulses, the individual pulses which activate generate action potentials, that's been known for quite some time and it's been explored since 60s, and by, I think, 70s, 80s, we actually knew what we wanted to have. What is really a trick is how to design different muscle contraction sequences to get fine motor control. So one of our contribution was stimulation of the intrinsic muscles of the hand to get, like moving of the biceps and triceps and all these things was available even when Thierry and I, we started working on it. We copied others, which worked very well. But what we need to discover was how to stimulate intrinsic muscles. The other thing which was problematic for me and was that when you provide electrical stimulation, it's unpleasant. It will cause you, as it moving the hand, you're getting sensation of discomfort that you're doing that. So we fortunately were lucky and came up with a new pulse shape that removes that problem completely. Not completely, but substantially. So it's much more comfortable, and then we don't have any problem with adherence with patients. Would they want to participate because it's not uncomfortable? So that was another breakthrough. So fine motor control, ease of use of the device, and non-painful stimulation, plus the clinical data was sufficient for the company to launch and attract the funding and whatnot. Yeah.
Okay, thank you very much, Milos.